Hello friends, I am Dr. Chaitanya and welcome to my channel Critical Care Basics. In this channel, as you all know, we are running ECG tutorials and this is the 31st ECG tutorial. The topic of today's tutorial is atrial fibrillation. Apart from sinus tachycardia, atrial fibrillation is the commonest tachyarrhythmia that you will encounter in your clinical practice. That is why I have taken the liberty to go in detail about atrial fibrillation. So probably we'll end up making 2 or maybe 3 lectures on atrial fibrillation. So let's start atrial fibrillation. Atrial fibrillation part 1. As I just said, atrial fibrillation is the most common cardiac arrhythmia and most treated arrhythmia. More than 4% people above 60 years of age will have atrial fibrillation sometime in their life. What is atrial fibrillation? It is a supraventricular rhythm, tachycardia, and the characteristic feature is uncoordinated atrial activation without effective atrial contraction. The atria are not contracting like this, but they are just ceasing as if atria are having epileptic foci. So there is atrial ceasing, there is no effective atrial contraction. Excitation and recovery of the atria are disorganized and chaotic. The P waves are replaced by fibrillatory F waves, which are coming at a speed of 400 to 600 per minute, and irregular ventricular rhythm, that is RR intervals, are changing. For example, in our last video we have seen atrial flutter. So atrial flutter has flutter waves replacing the P waves, but they come at regular intervals and there is no isoelectric line in between them, giving a classic sawtooth appearance. And usually there is a fixed AV conduction, 2:1, 3:1. In this strip, however, there is a variable conduction, like after 3 beats, 1 ventricular beat, after 4 beats, 1 ventricular. So this is a variable conduction in this strip, but usually atrial flutter is a fixed rhythm. While atrial fibrillation, you do not see any fibrillatory waves at all usually. What you see is a undulating small undulations on the isoelectric line, and what you clear cut most easily notice is changing RR interval. In the lowermost slide, you have multiple P waves of different shapes. Here also the rhythm is irregular, but there are multiple P waves. So this is neither flutter nor atrial fibrillation, but this is multifocal atrial tachycardia. We'll come to it later on. Some terms that we have to be accustomed to in atrial fibrillation. The paroxysmal or intermittent AF is atrial fibrillation that terminates spontaneously with or without intervention in less than 7 days. Persistent AF that fails to self-terminate within 7 days, often it requires pharmacological or electric cardioversion. Long-standing persistent AF, that is AF lasting for more than 12 months. Permanent AF is a persistent AF where joint decision has been taken by the physician as well as by the patient not to pursue rhythm control. That is, only rate control strategy is being followed. Silent AF, asymptomatic. The patient does not know that he has AF, he or she has AF, and it is detected during routine examination. Lone AF is an outdated term. This was initially used for those patients who are less than 60 years of age and they do not have any structural heart disease, any cardiopulmonary disease, no hypertension. So if such a patient who otherwise does not have any risk factor for atrial fibrillation but is found to have atrial fibrillation, initially this term was used, lone atrial fibrillation. This is no longer used. Similarly, non-valvular AF and valvular AF. These terminologies are also outdated now. Non-valvular AF means AF in absence of rheumatic mitral valve disease, usually mitral valve stenosis. Now, why AF is important? AF is important because first of all it is very common. It is most common tachyarrhythmia that you will encounter in your practice. About 1 to 3% of general population has AS. 3 to 6 million in US, 8.8 million in EU, and the overall global prevalence is 33.5 million. That was the data in 2010. So imagine how many people must be suffering from AS. 2% of the general population, and above 80 years of age, 5 to 15% of people will have AF. The main thing is, the dangerous thing is, with AF, there is 5 times increased chance of developing a stroke, 3 times increased chance of developing heart failure, and 2 times increased chance of developing dementia. Patients with AF and heart failure have higher risk of post-operative mortality following non-cardiac surgery. So even if a patient has come for a relatively minor procedure and he or she has AF with elbow dysfunction, so the patient is likely to have higher mortality and morbidity during or after the procedure. AF is a multifactorial problem and there is no specific cause. Anything that stretches causes structural problem, remodeling, fibrosis, stretch, or physiological problem, functional problem like increased pressure or electrical problem. Anything will cause atrial fibrillation as a terminal pathway whenever atria are in geocardia. Hypertension is the most common cause or you could say associated factor for atrial fibrillations. 60 to 80% of people with atrial fibrillation will have hypertension. Second is cardiovascular disease, including cardiomyopathy and valvular or coronary artery disease, 25 to 30%. Heart failure, New York Heart Association class 2 to class 4 will have many people will have atrial fibrillation. Diabetics is also important risk factor. 20% patients of atrial fibrillation will have diabetes. And age is the most common factor, most important factor, because above 80 years of age, 5 to 15% of people will have atrial fibrillation because age causes fibrosis and fibrosis causes atrial fibrillation. Post-operative atrial fibrillation, cardiac, pulmonary or esophageal surgery will may result in atrial fibrillation. Pulmonary arterial hypertension, especially due to pulmonary embolism, this is an important risk factor for atrial fibrillation. Any inflammation of the atria, pericarditis, myocarditis, rheumatic carditis may cause atrial fibrillation. 2 important endocrine causes, hyperthyroidism and pheochromocytoma. Ventricular pacing or any external device into the atria will increase the risk of atrial fibrillation. Brain problem, subarachnoid hemorrhage or hemorrhagic stroke increases the risk. That's why hemorrhagic stroke is incorporated in CHA2 DS2 VAS score. Importantly, obstructive sleep apnea increases the chance of developing atrial fibrillation by 4 times, fourfold. Metabolic syndrome, insulin resistance, BMI more than 25 and waist circumference more than 102 in males and 88 in females. This metabolic syndrome has a higher chance of developing atrial fibrillation. Normally we used to consider that taking alcohol 1 or 2 pecks daily is good for the heart, but it is not good for the atria. So even 1 or 2 pecks daily for a long time or an alcoholic binge may result in atrial fibrillation. Electrolyte disturbances, especially hypomagnesemia. Some people will have familial AF, including those people with channelopathies. Psoriasis is an important risk factor for atrial fibrillation. If you do regular exercise, that is good for the heart. That will actually help in prevention of atrial fibrillation. But people who are doing vigorous, long-standing exercise, especially the athletes or marathon runners, will have 2 to 10-fold increase in the chance of developing atrial fibrillation. Drugs, cocaine, amphetamine can cause AF. And lastly, lone AF, as we discussed, when AF is detected at a relatively young age without any obvious cause. So, any problem in the atria, any structural abnormalities like fibrosis, dilatation, ischemia, infiltration, hypertrophy, anything will cause AF. For example, if there is inflammation or oxidative stress, that can cause atrial abnormality. Atrial abnormality can cause AF. Renin-angiotensin-aldosterone system gets activated, and this can itself cause atrial structural abnormality, causing AF. Extracardiac factors like hypertension, obesity, obstructive sleep apnea, hyperthyroidism, alcohol, and drugs. These also cause structural problems with atria and resulting AF. Atrial tachycardia can cause remodeling, causing structural abnormalities including fibrosis, which can cause AF. Some genetic variants like channelopathies and cardiomyopathy again will cause structural atrial problem causing AF. Atrial electrical abnormalities will cause increase in heterogeneity, that is called anisotropy. What does it cause? It causes increase in the re-entry. Any problem with the conduction, any problem with decreased action potential duration or increased automaticity always cause AF. So AF is a multifactorial problem which can happen due to anything that involves the atria. Any problem in the atria may be structural, electrical, or a trigger loop or hemodynamic loop will ultimately lead to AF, and one loop will involve the other loop. For example, if the patient has some hemodynamic problem, suppose the patient has rapid ventricular rate or hypertension, it will cause LV dysfunction, ventricular filling defect, will cause chronic atrial stretch, and this will cause AF. AF in turn, similarly, valvular disease will cause chronic atrial stretch and AF. This AF will cause rapid atrial rates. This will cause calcium overload. And as we know, calcium overload causes increased activity of sodium, calcium exchange ion channel, which causes increased delayed trigger activity. Again, ectopy, which will lead to atrial fibrillation. Electrical loop, calcium overload causes change in ionic currents, will again cause re-entry circuits, again cause AF. Similarly, whenever there is myocarditis or some hypertrophy, simply aging will cause fibrosis, will cause slowing of the conduction, again re-entrant circuit and AF. Especially fibrosis causes AF and AF causes fibrosis. Therefore, it is called that atrial fibrillation begets atrial fibrillation. Right? So initially the patient has a paroxysmal type of atrial fibrillation, then it becomes permanent. Now, there are various hypotheses concerning the mechanisms of atrial fibrillation. One is multiple wavelets, typical micro re-entry, or rapidly discharging automatic foci, or a single re-entrant circuit with fibrillatory conduction, or functional re-entry resulting from rotors or spiral waves. And lastly, AF maintenance resulting from dissociation between epicardial currents and endocardial layers. Coming to the ECG changes in atrial fibrillation, we will discuss this in 6 different headings: atrial activity, ventricular activity, regularization of AF, AF with complete heart block and escape rhythms, AF with VT, and AF with WW. Let's start with the atrial activity. Atrial activity is typically absence of P waves. They are replaced by small undulations in the isoelectric line, which are called as fibrillatory waves. They are most commonly seen in lead 2 and V1. So these are small undulations, these are fibrillatory waves. The rate is typically 350 to 600, and if present, they are best seen in the inferior lesion V1. The F waves may be identified between the QRS complexes. See, these are the QRS complexes, and these undulations are the F waves, or they may be superimposed on the T waves or the ST segments. Second is the ventricular activity. Ventricular activity, the typical feature is irregular, meaning lacking a repetitive, predictable pattern. The RR intervals are continuously changing. The ventricular rate in absence of AV blocking drugs is usually between 90 to 170. In fact, as per the ventricular rate, the AF is categorized as AF with a slow ventricular rate less than 60, AF with a moderate ventricular rate 60 to 100, and AF with a fast ventricular rate or rapid ventricular rate when the ventricular rate is more than 100. The QRS complexes are narrow unless there is a conduction problem in the bundle branch or the His-Purkinje system, or there is an aberrant conduction pathway. You see the changing RR and the small fibrillatory waves. When the fibrillatory waves are larger and they can be noticed, then that is called as coarse atrial fibrillation, or when they are very small or they are practically absent, that is called as fine atrial fibrillation. Now, what is regularization of atrial fibrillation? In this ECG, this patient has atrial fibrillation and you cannot see the P waves, but what you see is a regular rhythm, but a very slow ventricular rate. Ventricular rate is around, say, 30 to 40 in this patient. So, this is escape complex with complete or high degree AV block. Complete or high degree AV block may be caused by conduction system disease or after AV node ablation. AV node ablation is one of the treatments that is done in atrial fibrillation, or it could be due to drugs, and namely, most importantly, digoxin. So, you can see that there is no P wave and there are small undulations that could be fibrillatory waves, and these are the escape rhythm arising from the bundle. If the escape rhythm arises from the bundle, the rate would be around, say, 50 to 60, right? So it will be regular rhythm because there is block. The atrial fibrillatory waves are not carried downwards in the ventricles. What is going down is the escape rhythm that is generated from the junction. So, if it is junctional rhythm, the QRS will be relatively narrow and the rate will be around 50 to 60. If the rhythm comes from the ventricles, escape rhythm, then the QRS would be wide. So, this is coarse atrial fibrillation, but because this is escape rhythm, this is looking irregular. So, sometimes in presence of complete heart block and escape rhythm, though the patient has AF, the rhythm may look regular. In this patient, the patient has a dual chamber pacemaker in situ with one lead in the atria and one lead in the ventricles. So here you could see something like a small P wave. So probably you may feel that the patient does not have atrial fibrillation, but then the ventricular lead in the atria was switched off and the mode was changed to VVI, that only ventricular pacing, and now you can see the typical fibrillatory waves or atrial fibrillation, and these are the pace beats. When the patient has severe tachycardia or AF with fast ventricular rate, then especially on the monitor, you may not notice that RR intervals are changing. Naturally, there are no P waves. Even if it is sinus tachycardia or supraventricular tachycardia, you may not see the P wave, and the rate is very fast. Here, the rate is above 150 or around, say, not above, above 150. So, what will you say? What 160, 170 is the rate. So, if it is on the monitor, so you may not notice that RR interval is changing. In that case, you could give adenosine and reduce the rate, and now the AF will be evident. In this ECG, you see what is called as pacemaker pseudofusion. Patient has atrial fibrillation, with fully paced rhythm, and in beats in complexes 1, 5, 6, 7, 8. These are the paced complexes. While 2, 3, 4, as you see, there are no pacing marks here. So these are the intrinsic native ventricular conduction. And what you see in 9 and 10 are the complexes resulting from the same. It has the same morphology as the native ventricular beats, but this pacemaker line preceding that. So this is not pure fusion, but is pacemaker pseudo fusion. AF with ventricular tachycardia. This can confuse sometimes with AF with aberrant conduction. This is a strip, irregular, regular, but here you see very regular rhythm, wide QRS, and this is ventricular tachycardia. Now, AF with aberrant conduction. So, this is a common cause of QRS widening during AF. Most aberrancy is tachycardia dependent, although sometimes it could be bradycardia dependent. The aberrant conduction in AF involves a rate related change in conduction, typically a functional bundle branch block. What is a functional bundle branch block? That if the rate is fast, the right bundle branch is refractory for a longer time because it takes a longer time to recover, right? So what happens if the rate is very fast, before the next beat comes, the right bundle branch has not yet recovered, so the ECG shows right bundle branch block pattern. So that is called rate dependent, or whenever the rate is slowed down, the RBB will vanish. So that is called rate dependent RBB aberration. This is a patient with atrial fibrillation and also has left bundle branch block pattern. Now, Astral phenomena can also occur in AF. What is Astral phenomena? In myocardium, refractoriness is longer at slow rates and shorter at fast rates. So, for example, in AF, in beat to beat, the refractoriness of tissue will change. Here, the rate is fast, and here there is a longer coupling interval. So, after this longer coupling interval, the refractoriness of bundle branch takes a longer time to recover, right? Especially the right one. And after long coupling interval, if a second beat comes early, then the right bundle branch would be refractory, and what you will get a pattern will be RBB type pattern. Now what is happening here? This is a patient with AF, and due to long coupling interval, due to Astral phenomena, you can get right bundle branch block pattern intermittently, and sometimes this can come in couplets. But sometimes functional RBB activation down the LVBB is followed by partial penetration up the right bundle branch block. For example, after Astral phenomena, sometimes what happens? The right bundle branch, the impulse comes down through the left bundle branch and goes up the right bundle branch, causing functional right bundle branch block, and this is not seen in the ECG. That is why it is called concealed conduction. So if you look at this ECG, what you see is these are the beats due to Astral phenomena. These are the right bundle branch block, and suddenly now you see a regular white complex tachycardia. So this is not VT, but this is RBBB due to concealed conduction, right? Now this is most important, atrial fibrillation with WPW syndrome. As we all know, what is WPW syndrome? There is an aberrant pathway for the current to reach from the atria to the ventricles apart from the AV node. So the impulse reaches the ventricle before the impulse from the AV node comes, and that is responsible for the typical delta wave. That is responsible for the typical delta wave in WPW, that is called as pre-excitation. Ventricular response rate may be very rapid, 200 to 300 per minute. So this is a medical emergency. Pre-excited AF is facilitated when the refractory period of access pathway is very short, and this accessory pathway has a shorter refractory period because the pathway has the action potential due to sodium current, depolarization due to sodium current, while the AV node has a slow conduction due to slow AV action potential, slow action potential due to the depolarization is due to entry of the calcium ions in the slow action potential in the conduction system, while here in the accessory pathway the depolarization is due to fast sodium current. So accessory pathway will conduct the current very fast to the ventricle, resulting in what is called as delta wave and fast ventricular rates. A distinguishing feature of atrial fibrillation with pre-excitation is the relationship with the heart rate. The more the heart rate, the wider will be the QRS. So this is an important distinguishing point. So this is a patient of AF with WPW syndrome. So you see the typical delta waves, right? And naturally there is no P wave, so we cannot talk about a PR interval. So this is a patient who you have to remember that in this patient you do not have to give any drug which causes slowing of the AV conduction. For example, you cannot give amiodarone, you cannot give beta blocker, or you cannot give calcium channel blocker or digoxin, right? Otherwise, the conduction in the accessory pathway will increase and this patient will die. So I request you to see the video of Dr. Mattu. In his lecture he has said how not to kill, how to avoid a clean kill in wide complex tachycardia. So this is one of those circumstances. If the patient has wide complex tachycardia, irregular tachycardia due to AF plus WPW, if you do give this one of these drugs, amiodarone or AV blocking drugs like beta blocker or calcium channel blocker, you can kill this patient, right? So this is most important to avoid giving those drugs. The best treatment for this patient would be cardioversion. If at all you want to give a drug to control the ventricular rate or to normalize the rhythm, you could try albuterol. So what are the differential diagnoses of atrial fibrillation on ECG? It could be sinus arrhythmia, where you can see the PP variation. So the P waves are very evident. So usually you should not confuse sinus arrhythmia with AF. But when there is sinus arrhythmia with junctional escape rhythm, so sometimes that could be confusing. Variation in PP interval, one or more QRS without preceding P waves. Sinus rhythm with second-degree AV block, sinus rhythm with premature ventricular ectopics or atrial ectopics, or ectopic atrial rhythm, focal atrial tachycardia. What happens in ectopic atrial rhythm? Atrial rate is less than 100. You can see P waves that are different in shape from the P wave from the sinus node, but the rate is less than 100. So that goes in favor of ectopic atrial rhythm. We'll come to it again. Focal atrial tachycardia plus AV block. We have already seen a lecture on focal atrial tachycardia. Sometimes, in presence of AV block, you could see irregular rhythm with focal atrial tachycardia. But here, you could see the P waves. Atrial rates are about 140 to 180, and presence of AV block sometimes may mimic AF. We'll come to an example. Wandering atrial pacemaker. Here, in one strip, you see more than 3 different shapes of P waves, but the rate is less than 100. So this is usually wandering atrial pacemaker. And one-time focal atrial tachycardia. Here again, you could see more than 3 P wave morphologies, but the atrial rate is more than 100. This will become more clear when we see examples. So, what is the approach to a irregular or irregular supraventricular rhythm? First, you see whether the patient, the ECG is showing any active artifact. If there is an artifact, you repeat. Then you identify the atrial activity. Then you increase the amplitude if the P waves are not very clear. Then examine the atrial activity and then rule out AF mimics. For example, when you see the ECG, Do you see an artifact? Yes, then repeat pressing. No, you can see the atrial activity. Then can you see the flutter waves? Flutter waves are very typically easy to identify. They are very easy to identify. So there is no isoelectric line and typical sawtooth appearance. If you see this in irregular rhythm, probably this is flutter with variable conduction. If P waves are present, what is the P wave morphology? If there are fibrillating waves, and then with irregular rhythm, probably this is atrial fibrillation. If P waves are present, whether there are only sinus P waves or sinus P wave plus at least one more P wave morphology, or there are more than 3 P wave morphology. If there are only sinus P waves, then it is sinus arrhythmia, or sinus arrhythmia with competing junctional escape rhythm, or sinus arrhythmia with second degree AV block, or sinus rhythm with ectopics. If you say one more P wave, if it is isolated non-sinus P wave, then it is sinus rhythm with atrial ectopic. Are you getting my point? You see one sinus P wave plus one extra P wave which is not sinus, but then that is the only isolated P wave different than the sinus P wave. In that case, it could be atrial ectopic. If you see runs of P waves which are not looking like sinus, then if the atrial rate, just get my point, this is not, we are not talking about the ventricular rate. If the atrial rate is less than 100, then it could be ectopic atrial rhythm. If the atrial rate is more than 100, then this could be focal atrial tachycardia. Lastly, if there are more than 3 P wave morphologies, right? So 3 different types of P waves in one strip, and the atrial rate is less than 100, then this is wandering atrial pacemaker. While if atrial rate is more than 100, this is more likely to be multifocal atrial tachycardia. We'll see some examples. Now this is junctional escape rhythm. So one thing is there are no P waves. Now you see one irregularity, otherwise you see regular rhythm. What is happening here? See these waves. So these are similar to P waves. They are coming sometimes after, sometimes before the QRS complex. So these are the retrograde P waves. They are going from, the conduction is going from below upwards. That is why they are inverse P waves, or that are called P prime waves. So these are the P waves, the P activation is going from below upwards. So this is a junctional escape rhythm. Now what do you see? This is looking like an irregular rhythm, but you see P waves. The P wave morphology, however, is showing more than 3 types. This is one P wave, one shape. This is another shape. This is third shape. So at least 3 different shapes of P waves, and the atrial rate is definitely more than 100. So this is likely to be multifocal atrial tachycardia. Now what happens when there is second degree AV block? Second degree could be Morbid's type 1 or type 2. For example, here you see irregular rhythm. So you may think probably this is an atrial fibrillation, but are you seeing P waves? Yes, you do see P waves. However, the PR interval goes on increasing, and then there is loss of QRS complex. So this is ventricular. We'll come to it when we study about the blocks. But this irregularity is not AF, but Morbid's type 1, second degree heart block. Here, you see that the QRS rate or the ventricular rate is very less, about between 30-35, and what you see is no P waves. So is it atrial fibrillation with slow ventricular rate? No, because you do see something which could resemble a P wave. For small P wave here, small P wave here, and it is not getting conducted. So this is advanced second degree heart block, almost impending complete heart block. So this could be another picture which can confuse you with slow AF. Now focal atrial tachycardia with variable conduction. As we discussed, how will you see focal atrial tachycardia? You will see a P wave other than the sinus P wave, but the rate would be more than 100 atrial rate. So see the lot of P waves here, 1, 2, 3, 4, but they are all similar, only one type, and the atrial rate is more than about here 200 or 230. So that is focal atrial tachycardia with variable conduction. The rhythm may seem irregular, RR interval may seem irregular, but these similar type of P waves which are different from the sinus P wave tells you that this is not AF but focal atrial tachycardia with variable conduction. So that was all about the AF, ECG and the differential diagnosis of AF in ECG. In next lecture, we'll talk about the clinical features and the treatment of AF. Stay tuned. If you're liking these lectures, do like, subscribe and share. Thanks a lot.